Welcome back to Therapeutics. And in this, one of the last blocks of the year, Geriatrics, we'll review a lot of concepts we've talked about throughout the year. So there's actually not too much on here that's new, but it might be framed in a different way, particularly related to older patients. So a lot of this content is review, but it's a nice way to sort of summarize the year as well as have our discussion really focus on older patients. In practice, I think you'll see a lot of patients who are older unless you happen to work in pediatrics. But short of that, geriatric patients are very common in most practice settings. And looking at these individuals who have lots of unique issues as well as issues that are common among all patients are important for us. So the objectives are listed in this slide. When we have conversations with our older patients, important to relate to them as best we can and empathize with what their concerns, fears, and frustrations are. And as you can see in this image, important with all patients, but with older patients in particular, to try to remain at eye level with them in our conversation. And if it's culturally appropriate, to also really manage that conversation in a culturally sensitive way with eye contact if that again is appropriate to do. What are some of the things we think about? There's lots of things in older patients, but primarily older patients compared to younger patients have a lot of things that are going to affect drug absorption, distribution, metabolism, and elimination. And we'll talk about those issues specifically. First of all, the pharmacokinetic issues, minor issues, but older patients often have reduced gastric acidity. Half the time, or more than half the time, it's because we have them on medicines that slow GI, reduce GI acidity. They also might have reduced gastric emptying time, particularly if they're diabetic, and so that's going to be an important issue for us as well. Drug distribution is an issue particularly for drugs that are fat soluble or drugs that are water soluble in patients who might be dehydrated. And so a few key issues for us relate to drug distribution in older patients. The key things I think of in older patients is that they have less percent of their weight as body water to start with. And so for drugs that are fat or water soluble, the volume of distribution might be affected. But in addition, with the less body water, there's pretty easy for them to become dehydrated with diuretics. And so in heart failure patients, we are often chasing after finding that perfect line between dehydration and having them go into renal failure and falls risks versus too much fluid on board with their heart failure. And so that becomes a narrower tightrope for us to walk in older patients than it is in patients who are otherwise relatively younger. We also have to think about increased body fat in drugs that like to hang out in fat. So drugs with the high volume of distribution, classically benzodiazepines or other sedatives, can hang around longer in older patients. And that has some issues related to, among other things, hangover effect and dosing. Older patients also have reduced albumin on average. That certainly, if they have liver failure, that's more common. But older patients in general, particularly those who might be nutritionally deficient, have less albumin. And that means for highly protein-bound, albumin-bound drugs, those drugs are going to have a higher percent of free fraction and ability to cross membrane. So that's an issue for us for those very highly protein-bound drugs. While there are a lot of issues with drug metabolism across adults and folks with aging, there aren't really a lot of big implications specifically about reduced drug metabolism in old age. What we do see, however, though, is that older patients are likely on many more drugs, and just by increasing the number of drugs, the likelihood that there are going to be interactions that involve drug metabolism are much greater. And so that's really the key issue for us in older patients. And finally, elimination. The big issue is glomerular filtration reduced with age. And so almost all patients who are older need to have any drug that's renally cleared to have that dose adjusted uh, with aging because of their decline in renal function. The other issue we worried about is that there's less reserve capacity in that renal function, and so drugs that are nephrotoxic are also more problematic in this population. So there's less wiggle room, there's less body reserve in terms of, among other things, renal function in old age. There are lots and lots of drugs that require either cautious use because they're nephrotoxic or require adjustment in dosage because they're cleared renally. Here's a list of some of them. But we talked about that a fair amount throughout the year, and I'd encourage you to also look at your pharmacologic compendium, your references as your, particularly in your first clinical year and your early few years of practice to become more familiar with the drugs that require dose adjustment and renal dysfunction. So in summary, some of the things that we'll see with pharmacokinetic changes with aging are some changes in absorption, and we also talked about earlier thinning of dermis, so we worry about drugs, absorption via the dermis more significant in older patients. But also with less body water and more body fat, drugs that have a very large or small volume of distribution are affected, as well as albumin binding. We also worry somewhat about liver, but renal is the real issue for us in reduced renal function over time. And so we really want to be aware of renally dosing drugs for patients who are older. One of the big key things I worry about or I think about is that when we use formula or when the lab calculates an estimated creatinine clearance for a patient, you want to be really aware of that calculation is an estimate based on a formula. And there's variation in that formula. Sometimes that variation can be dramatic based on the formula you use, while their true renal function may not be reflected in that formula. On top of that, you want to really keep in mind that patients who have very little body weight, those patients we really are really concerned about overestimating their kidney function. That if they have very little muscle mass, to explain that serum creatinine of 0.6, their kidney function is actually not very good. So we want to be aware of that as well. In addition to pharmacokinetic changes with older patients, we see pharmacodynamic changes with sensitivity at receptors. We see this all the time with lots of drugs that are listed here, but particularly we see the drugs that I see older patients really become sensitive to are benzodiazepines, which we try to avoid in older patients, and the opioids, where patients sometimes have a significant change in mental status with opioids, and we have to be careful about that, but keeping in mind that we adequately want to manage the pain as well. Some of the other drugs that are problematic are anything that can cause orthostatic hypotension. The anticoagulants are always concerning to us, and the NSAIDs with the risk for GI bleeding in older patients in particular are problematic. In addition, with older patients, we worry about nephrotoxicity with NSAIDs. Other things you'll see are the beta agonists and beta blocking drugs may be less responsive in older patients than otherwise. And we really worry about things that affect hydration status, diuretics, or things that affect the angiotensin converting enzymes or ARBs, how they affect sodium and electrolytes and potassium. Other things we worry about in older patients is their overuse of medicines. We'll talk about polypharmacy quickly in a minute. We worry about underuse occasionally where clinicians are fearful of adverse effects, and so we don't, for example, or may elect not to anticoagulate a patient that may put them at a higher risk for a stroke or something. We look at adherence issues in older patients, and it might be that it's often unintentional, but the more complicated the regimen is, the more difficult it is for a patient to adhere to it without support. They may have some cognitive impairment that makes that more difficult. There may be cost issues that interfere with the patient's ability to even get the medicine, so never assume the patient is getting the medicine filled unless you have that kind of frank discussion with them. We also look at other kinds of issues. We'll talk about the Beers criteria, for example, in a bit, and withdrawal syndromes in older patients. Some of the ways to sort of think about this, and this is sort of becomes intuitive in practice, but you kind of want to be clear that there's a clear reason and rationale, and the benefit outweighs the risk for every medicine that's on any patient's list, but particularly in older patients, it really is sometimes difficult to recognize how common patients may be on some of these meds that no longer have the benefit they once had and may have increased risk based on the comorbid states that have kind of arisen over the years. So as you think about it, you want to be clear that some of the questions that are listed here include, is it an indication for every drug that they're on? Is it really working? Is the dose right? Does the patient understand how to take them? And are they practical directions for them? Are there any significant drug interactions, drug-drug or drug-disease interactions? Do you have drug duplication you want to avoid? Do they still need to be on this medicine? Is the duration of therapy appropriate? And then finally, number 10 is, what is the cost for that patient? Is it covered by their insurance, or is it expensive? Are they making decisions to choose this med versus their grocery budget, for example, or their housing budget or something like that? So you want to kind of be clear about that. The other thing that affects costs in older patients, at least in the last decade or so, is patients who are on Medicare will have something called the donut hole, which is they will go through their drugs will be covered up to a certain point in the year, and then maybe mid-year, all of a sudden, they have used up their entire pharmacology or pharmacy budget, and all of a sudden the medicines become much more expensive for them until they reach a higher level of contribution when they come back down again. And so that's called the donut hole, and it usually happens sort of mid-year in their cycle of their annual Medicare benefit process, and so you want to be aware of that as well. Important in practice that you look at the functional status of the patient who's in front of you. So that should be true for everyone, but particularly in older patients, you want to be sort of doing a quick inventory of their quality of life. Where do they live? Can they be as independent as possible? What is the value system for that individual? And what can you do to keep them in their desired residential setting as long as that's possible? You also want to make sure that that's safe for them to do. You want to get some assessment of what are their activities of daily living. Can they manage daily living themselves, or do they need assistance in doing those basic things? What's their financial ability and their ability to manage their finances and their shopping and their meds, and do they need supports, and to what extent are supports available for that individual to remain at home? Also, kind of important in older patients is to periodically evaluate their cognition. And there are multiple different tools here. Obviously, you want to pick the one that works well in your setting and what's supported. The simple mini mental status eval has been used for years and years, and it's a pretty simple test, but it gives you a quick assessment of where folks are over time, and that can be incorporated in the assessment or evaluation. Important to find some way to assess for depression and risk for depression. Many clinicians look at depression in older patients might present differently than younger ones. Looking at gait and balance with them, what's their falls risk? Are there drugs that can affect cognition or mood or mobility? So that all of those are important to look at. Also looking at their falls history and their falls risks. Are they orthostatic? And then what's their calcium, vitamin D, and bone density related to that? Are they at risk for delirium, and what are the risk factors for that? And then some of the things that actually aren't listed in this assessment but clearly should be are issues of nutrition. So what's the nutrition issue for a patient, and what are the barriers for a patient to be nutritionally deficient? Is it financial? Is it ability to cook in meals? Is it taste alteration? Is it dentures? What's the concern, and is it depression? And as we talked about with depression, it is very commonly for clinicians these days to use mirtazapine, for example, as the antidepressant of choice for someone who might be losing some weight. So what kind of assessments, and how do those assessments sort of relay to how you're managing their overall comorbid conditions? What we really try to do is to try to avoid hospitalization when that's reasonable and possible. Because what does hospitalization do to older patients? They often will lose ground that they may never gain back again. That immobilization leads to deconditioning that is very hard for some folks to regain after hospitalization. They have a blunt or a sensory deprivation that leads to delirium and falls risk. The immobilization might also be a function of IV lines or catheters or something else. They have to ask, they've got a bed alarm going off if they want to get out of bed without assistance, so they have to wait for somebody else to help them get out of bed. There might be NPO for tests, but that affects hydration and nutrition. And the drugs that we use in the hospital themselves are sometimes more toxic or more problematic. So hospitalizations, take their toll on older patients in lots of ways. And I think clinicians try to do everything they can to stem the tide to avoid a hospitalization. The whole question of hospitalization also becomes an issue later on in more frail older patients who may transition to a palliative care or a hospice care approach later in life, when one of their goals is to do everything we can to be clear about avoiding hospitalizations for a patient and instead try to manage their symptoms or condition outside the hospital. We referred to throughout the year, but here as well, again, polypharmacy. And there's lots of ways to define polypharmacy, but I think the simplest one is you've got a drug on board for which the risk outweighs the benefit. There's not a clear benefit to that drug compared to what the risks are. And ways that we more finely tune that are using a drug without an apparent indication, or duplicate meds that interact in some ways in negative ways for patients that could be done more safely, or doses that are inappropriate in one way, shape, or form. And we often can tell that there was polypharmacy with hindsight when we trial somebody off of a medicine and they actually do better. And in practice, we see that all the time. Some factors that contribute to polypharmacy is just that it's easier to write a prescription than it is to stop one. And we see in older patients, they have more comorbid states and they have more symptoms. There's if they watch consumer advertising, these medicines are advertised all the time directly to consumers, and so there's a sense of that. There's also a financial sense that, okay, I bought these meds, I spent $375 for a month's supply of this medicine. Even though we're going to stop it, I'm going to keep it in my medicine cabinet because it's expensive. Maybe somebody else I know can use it, without talking with their providers about that risk, because they spend a lot of money on it. So, all of these kind of things that are listed as bullet points here sort of contribute to that. And I think intuitively, we've talked about some of these issues throughout the year. Some of the complications of polypharmacy are certainly more side effects, more drug interactions, non-adherence when it's complicated regimens, and certainly costs both related to the medications, but costs related to the adverse effects of the medications, including hospitalizations. There are lots of studies that have looked at the more meds on board, the riskier that is for patients. Here's one really older study, 20-year-old study, but it rings pretty true. They looked at this population and they looked at the nature of who had adverse reactions and preventable adverse reactions, and there was a clear correlation with the types of adverse reactions that happen with meds and the number of meds patients were on. And so patients who had more meds had a much higher odds ratio for an adverse event. And the nature of adverse events were often, as in the previous slide had noted, were central nervous system complications, but others as well, including falls. So I think it's important for us to do is have a systematic approach for our ability to manage and prevent polypharmacy. So in summary here, before we kind of get into sets of reviews of some more specific things to think about, in summary, I'd encourage you to have an approach when we think about drug therapy for anyone, but particularly for older patients. In my mind, these are sort of intuitive, but let's sort of go through them. I think it should be it's very helpful for all patients, but particularly older patients, to set a treatment goal and establish a clear indication for every medicine. So there should be baseline functionality before we start a med. You probably want to look at somebody's orthostatic blood pressures, do a mini mental status eval. What's their baseline bowel function, urine and urine incontinence issues? What is their baseline weight, height, albumin, nutritional status? What's their falls risk? And when you get in the clinical arena, you'll get a better sense of different tools that are used in gerontology for falls assessments, but medicines are part of that, particularly medicines that cause changes in cognition or orthostatic hypotension or dizziness. And so you want to be aware of all those medicines and the risk for falls, as well as medicines that can affect bone density in a negative way, where the falls risk then when they fall, there's a higher risk for a negative outcome with a fracture. So important for us to consider that. The other consideration with falls are patients who are on anticoagulants, and there are many of those. So the risk for trauma and hemorrhage and bleeding, and particularly head trauma, is really problematic with those patients. So you want to really be careful about that. Periodically, you should be evaluating the risk and the benefit of every medicine. That takes time and energy. Minimizing polypharmacy, keeping things as absolutely simple as possible with minimizing doses and frequency of dosing, managing interactions, maybe by pulling meds away, and then being clear about your communication with both that individual and their support network. So encourage their family member who's taking care of them or their friend, their neighbor, to join them on an appointment to come and walk through what they heard and maybe write down things so they can walk away with some written information, whether they read it or their sort of caregivers or friends or people in their household can help support them. And ultimately keeping things in their regimen as simple as possible. Okay, let's shift gears a bit and start to talk about some published guidelines or criteria. And these can look pretty detailed, particularly the Beers criteria. And what I'll try to do is not spend a ton of time on these, but talk about overarching principles. But the Beers criteria are published by the American Geriatrics Society every few years. They get updated. They've been around for about 20, 25 years. They're primarily based on expert opinion, as the other ones are as well. And we'll talk a bit about these criteria in the sort of takeaway messages with them. So first, here are the American Geriatric Society guidelines, the Beers criteria, that outline, for the most part, expert opinion in sets of tables. And the first set of tables, table 1, are drugs that are potentially inappropriate in older patients. And this goes on for a few pages here, but let me sort of cut to the chase about the issues we're most concerned about. Anything that is anticholinergic, antimuscarinic, is potentially problematic in older patients and should try to be avoided when that's possible. Only in that a lot of times we see folks with antimuscarinics, it often affects cognition. They have dry mouth, constipation, uh, uh, and so they become problematic for a lot of patients who are on these antimuscarinic meds. So we try to avoid those when possible. Also on this slide near the bottom on the right-hand column are in the antithrombotic category. You're always weighing the risk and the benefit of an antithrombotic therapy, but an older therapy that we really don't use much anymore is dipridamole, which used to be used as an antithrombotic in patients who had VTE risk or coronary risk, but the benefit in all patients is so diminished that it's really mostly risk without benefit, so we avoid those. As we sort of go on, you remember some of the things we've talked about through the year come back. We look at avoiding nitrofurantoin in older patients. If you don't have a serum creatinine a creatinine clearance that's above 30 mils per minute, you often don't have adequate levels of nitrofurantoin in the urine to treat cystitis. And so most patients, for example, in a nursing home, their creatinine clearance is typically below 60 and often below 30. And between 60 and 30, we generally try to limit nitrofurantoin because it may not work as well either. But a lot of patients really with poor renal function won't get any benefit at all from nitrofurantoin. So that's always something to keep in mind. And remember, nitrofurantoin just gets in the bladder, so it's only used for uncomplicated cystitis in women who have good renal function, period. Okay. Some of the cardiovascular meds that are listed here include the alpha-1, peripheral alpha-1 blockers, and the central acting alpha agonists like clonidine, due in part to mental status changes and also the risk for orthostatic hypotension. And so you always want to be aware of those risks and benefits, or anything that can cause orthostatic hypotension is always going to be a concern for us in older patients. And so you want to weigh, is there a compelling benefit compared to the risk? And one of the big indications for the alpha-1 blockers is BPH in an older male. And I think in the GU section, we talk a fair amount about the orthostasis risk. On the right-hand side here are other cardiovascular drugs. Digoxin is a second-line agent, even in AFib, for everybody. It's a narrow therapeutic index drug, so we really limit its use for AFib in patients for whom they're not going to be a candidate for diltiazem or a beta blocker. So that's important for us to know. Okay. Central nervous system agents that are listed below are some of the older tricyclic antidepressants in the bottom right-hand corner because they are highly antimuscarinic and they cause a lot of orthostatic hypotension as well as all the other antimuscarinic effects that we talk about. So the tricyclics we avoid. Now, that there might be a compelling reason that someone has significant neuropathies, neuropathic pain, and a low dose of a tricyclic antidepressant may make sense. But when we do that, we're looking at, do they have a lot of antimuscarinic properties associated with them, or are they orthostatic when they use them even at low doses, for which we're weighing the risk and the benefit, and maybe low-dose gabapentin makes more sense for them than the tricyclic antidepressant for their neuropathic pain. Okay, let's go to the next set of slides, continuing with meds that we would look at avoiding. Typically, the antipsychotics are not really first line, except in patients who have schizophrenia. So there's some data to say that the antipsychotics, when we're treating, for example, behavioral symptoms of dementia, that the environmental issues are first line, and that in delirium and dementia, the data is less clear for benefit, and there is probably a higher morbidity and mortality risk associated with them, that there's often more trouble than benefit. So antipsychotics we try to avoid in older patients whenever we can, particularly when we're looking at trying to manage dementia or delirium. Also, anything else that's really sedating. So we are going to avoid the barbiturates. We're going to avoid benzodiazepines, all of them, both short and long acting. They can contribute to confusion, delirium, and falls risk, among other things. So we're going to be careful about that. Okay? The other things we're even going to avoid are those that are anything else that's sedating, even like the other sleeping medicines like Ambien. We're going to avoid those. And that sort of completes most of what's on the left-hand column. On the right-hand column, there are a set of therapeutics in endocrine, estrogens and progestins and androgens that are sort of you're weighing the risk and the benefit. But the estrogens and the androgens, you want to be careful about the risks for prostate cancer in men with testosterone or androgens, and the risk for breast cancers and other cancers and thromboembolic events with estrogens. And I think we've talked a fair amount about that throughout the year. Going farther down, just keep in mind insulin or any of the medicines that are used in diabetes that can cause hypoglycemia are considered narrow therapeutic index drugs. And so in type 2 diabetics and anyone, but particularly older patients, metformin, pretty well tolerated. And some of the other, the GLP-1s and the others that don't cause hypoglycemia are preferred over insulin and over the sulfonylureas that are notorious for causing hypoglycemia and falls risk. So you want to be really careful about those issues. As we continue for further drugs to avoid the sulfonylureas, as I alluded to a minute ago about hypoglycemia, generally we avoid those. Let's go to the gastrointestinal drugs we avoid in older patients. One is metoclopramide, and the issue there with metoclopramide is the risk for tardive dyskinesia. So we try to limit it to not more than 12 weeks, and you probably want to get a GI consult, or maybe, depending on what your indication is, for either an endocrine or a palliative care or a hemonc consult if you've got a compelling reason to use long-term metoclopramide. But we generally try to avoid it because of the risk for tardive dyskinesia. We never give mineral oil orally in any patient because of the aspiration risk. And proton pump inhibitors, we worry about a number of things we've alluded to in the past, but C. diff in older patients and bone loss and bone fractures are higher in older patients. So with PPIs, as well as B12 deficiency. So you'd kind of want to weigh the risk and the benefit of that when you're using longer term PPIs in any patient population, but particularly older ones. As far as pain medicines go, no one ever uses Demerol and meperidine anymore. It is not all that effective. It has a toxic metabolite, and there are many safer opioid alternatives when you need an opioid. We try to do what we can to avoid standard NSAIDs in patients and avoiding their use because of the risk for both GI bleeding and for renal dysfunction. And so we look at trying to avoid those when we can. And then when there's a clear benefit, we look at weighing the benefit against the risk for the shortest duration of time. Particularly, the two that we really want to look at being careful about that are high GI bleed risks are on the top of the next page is indomethacin and ketorolac. Those are among the highest risk for GI bleed as well as renal dysfunction. We also want to be careful about the skeletal muscle relaxants where they may cause more sedation and cognitive dysfunction in older patients, as well as increase the risk for falls and fractures, so we're always careful about that. Okay, so that pretty much encapsulates their Table 1 categories of drugs or selection of drugs to avoid, which I don't think we said anything now that we haven't said sometime during the year. So that should just serve as a review for us. The second table they look at starts in the middle of the second page here. And these are potentially inappropriate or that may exacerbate a condition. So, for example, patients with heart failure, we're going to look at avoiding things that are known to cause fluid accumulation. You're going to weigh that against the benefit of what that drug has. But there aren't too many drugs that are really listed here. The NSAIDs may be, but you're going to weigh, I've got other concerns related to renal and GI more so than fluid accumulation. The other one I worry about are the glitazones with diabetes, which are really sort of drugs of later resort these days, and most folks will go to the endocrinologist before they order them. But in heart failure, those are the kind of things we kind of think about or worry about. We worry about patients who have syncope with anything that is going to predispose to syncopal episodes or orthostatic hypotension. There's a whole host of drugs. So anything that causes orthostatic hypotension, you want to be particularly cognizant, aware of, trying to avoid, because they confound your evaluation of their syncope or syncopal episode. Anything that is antimuscarinic or any benzodiazepines or other sedatives we want to avoid in delirium. And as we talked about, these are the very drugs that often trigger delirium, and so those get pulled away. We talked about that pretty much at length. Similarly, that same group of drugs we're going to avoid for dementia or folks who have a history of cognitive impairment. Then the upper right, another way to look at what we've kind of just talked about as well, are patients who have a history of falls or fractures. Well, anything that is either going to affect bone density and or is going to affect cognition or orthostatic hypotension are all the drugs we're going to try to avoid in patients with a falls risk, because you really want to avoid a fall and a fracture. Big issues. For folks with Parkinson's, we want to avoid anything that's going to cause EPS, extrapyramidal side effects. And so the antipsychotics or some of the antiemetics that have EPS side effects we're going to try to avoid and manage those carefully, as we talked about in the neuroblog. Folks who have GI bleeds, duodenal or gastric ulcers, we're avoiding the NSAIDs, and we're careful about the anticoagulants as well. So we're going to be careful, and we talked a bit about that. The kidney and urinary tract issues, folks who have kidney failure or some degree of kidney stage 4 or worse, renal insufficiency, we're avoiding the NSAIDs, and we're careful about how we use other drugs and managing protein and monitoring microalbumin, particularly in patients who have concurrent diabetes. For folks who have urinary incontinence, we're going to look at weighing the risk and the benefit of those therapies that will worsen it, particularly in women, particularly the meds that are used for BPH that help men may actually worsen things for women for their type of stress incontinence. We also worry about BPH and anything that's antimuscarinic. Okay, that's table 2. On table 3, they look at potentially inappropriate meds to be used with caution in older patients, not so much avoided. And this list is, being careful about aspirin and being careful about the DOACs, weighing risk and benefit. On the upper right-hand side, we talk about being careful about a whole host of meds that affect syndrome of inappropriate ADH secretion or hyponatremia that are listed there, particularly carbamazepine and the antipsychotics can do that. We also worry about using ACE and ARBs and renal function with other meds that can interfere with that, including Bactrim, for example. Table 4 looks at a number of drug-drug interactions, of which I'm not going to belabor that because that's true. These drug-drug interactions are true for most everyone. They list the ACEs and ARBs with other drugs, opioids, and then so the list goes on and on throughout this table. Just do a drug interaction check for older patients and being aware of that. Table 5 looks at drugs that should be avoided or dose reduced for patients who have kidney dysfunction. There are many of them. The fluoroquinolones are examples. Bactrim is an example. Other drugs to look at dosing adjustment or avoiding are listed on table 5. The DOACs, apixaban, rivaroxaban, dabigatran are all drugs that you need to be careful about with renal dysfunction, and you have to look at all of the criteria for dose adjustment with those anticoagulants because overdosing with those and the bleeding risk is significant. There are some other drugs listed here. A common one you'll see in the hospital is enoxaparin, And then when you use spironolactone in either heart failure or ascites, you're also worried about both renal function and potassium and elevated potassium levels. Okay. A number of other medicines are listed on the right-hand side of this table. That includes some central nervous system analgesics, the GI drugs that require adjustment, and colchicine and probenecid in patients with gout. The other issues we'll see in addition to the Beers criteria, here's an older set of criteria, but the bottom line in their recommendations are very similar to what the Beers criteria are, and these were more than two and a half decades ago in the Canadian approach here. Their approach looked at avoiding benzos, tricyclic antidepressants, barbiturates, MAO inhibitors, meperidine, antimuscarinics, and skeletal muscle relaxants. Okay, so a lot of those sort of repeated in the current recommendations. At that time, though, we still thought, well, shorter half-life benzos were safe. The newer guidelines say that even those lead to confusion, delirium, and falls risk, and so we avoid them whenever we can. An additional approach that started about a decade and a half ago were these lists of what meds should you start, because patients who are older may not have them on that list, and they should. That list is pretty small. And the stop list of things that are probably inappropriate and more consistent with the Beers list. The criteria for starting and stopping are, again, they overlap pretty well with the Beers list, so you see the same themes, and I won't belabor them here. But the criteria here are some of the cardiovascular drugs, central nervous system drugs, GI drugs. Again, a lot of the same culprits. I'd encourage you to stop the slide progression and just scan down these, which should be sort of a reiteration of a lot of what the Beers recommendations are. In addition, other drugs to avoid depending on conditions are listed. And then additional conditions where certain drugs are concerning, or you want to sort of look at whether you need to add them or take them away. As we wrap up our discussion in gerontology as a review, virtually everything we're going to talk from here to the end now is something we've already covered somewhere else in the curriculum. So this serves as a review. But in older patients, these are the common things you'll see time and again. And when you work with older patients, these are issues you want to have a little more familiarity with in general. That said, there are a lot of things that are not listed in these next sets of slides that are issues in older patients as well as younger patients that are not listed here. But some of the ones that are more pertinent primarily to gerontology are listed. So first of all, things that are involved in memory impairment or dementias and how that's compared with Alzheimer's. Here's a table that we talked about earlier in the year in neurology that kind of covered that. And so some of the differences we see with mild cognitive impairment or vascular dementia, Lewy body dementia, Parkinson's disease, or prefrontal dementia, how that compares across spectrum, and what are some irreversible versus reversible causes. And the reversible causes, whenever we have somebody with dementias or cognitive impairment, those are rewarding when you can change them, including a B12 deficiency, thyroid, hypothyroidism, depression. Those are really kind of the major sort of concerns here. We reviewed briefly, and I'm assuming you covered this also elsewhere, but Alzheimer's type dementia, the stages that you'll see: mild, moderate, and severe, and the presenting symptoms and the types of scoring and the mini-mental status eval scoring that patients have, and sort of where they fit and how their symptoms line up with that scoring. As a review, the treatment options for Alzheimer's type dementia are limited. They often don't offer a significant improvement in cognition, but they may sort of have a stronger track record in slowing the decline in patients with Alzheimer's type dementia. Those include the cholinesterase inhibitors or memantine or the combination of both of them. And typically, cholinesterase inhibitors are started sooner, and memantine often a little later for moderate to more severe dementia, where the cholinesterase inhibitors classically are started sooner. But keep in mind that the advantage to these agents are they may slow the decline, and that's not true with everyone. And they have significant side effects. So you want to start with a slow titration and manage those side effects pretty well. Many patients who have dementias will have a set of symptoms of behavioral or psychological symptoms that are really difficult for not only the patient, but their caregivers in particular, that lead to caregiver burnout and often are the reason why many of these patients are requiring placement in a setting for dementia, in a nursing home or some setting that allows for that, because of the burnout that these have. The pharmacologic interventions for each of these symptoms are targeted, but they're not perfect. They offer maybe some benefit, but not a lot. And the clear issue for many of these are to look at environmental supports and behavioral therapeutic options as opposed to drug therapy. But let's go through what some of the role for some when non-pharmacologic efforts are ineffective, where drug therapy may fit. For anxiety, maybe Buspar or SSRI may work. We try to avoid benzos though, because they will only usually make cognition worse. They will impair memory and make even patients often more fearful. Patients who are apathetic, you worry about, is their progression of dementia worsening, and are they candidates for cholinesterase inhibitors? If they have depression, you want to treat their depression with an SSRI and or mirtazapine. Mirtazapine is becoming quite commonly used in the cohort of patients, particularly who have less appetite or less willingness to eat. And so patients who have lost a lot of weight and have what looks like depression, mirtazapine offers the benefit of often making people feel like they want to eat more. And that's always worth a trial for patients. And if they then don't want to eat, despite the fact that they're on mirtazapine, then that you answer a whole different set of questions. When patients have interrupted sleep cycles, you do everything you can environmentally to do it, but that's pretty much it. Melatonin, maybe. I will tell you quite honestly, melatonin has probably the most data in sleep, jet lag kind of studies. The data for melatonin is limited. You will hear some patients who have more cognitive awareness say that melatonin for them helps, whereas other patients will say melatonin doesn't help them at all. But melatonin is pretty harmless, and so probably worth a trial at the very least. Nothing's going to help with wandering other than environmental supports, which are really hard. For paranoia and hallucination, an antipsychotic may be helpful, but you want to consider the risk and the benefit of those and try to use the lowest dose possible, and monitoring for any adverse effects. And then for aggression, again, not a lot of data. If you've got somebody who presents also with affect that's varying, there's been some limited data, and I don't know anything about this because I have no experience with it, with the combination of dextromethorphan and quinidine, but the data for that's somewhat limited, and I defer that to clinicians who have more experience with that as well. As far as issues in genitourinary, first of all, important to sort of remember what we talked about with the types of urinary incontinence and the drugs that can make some of those worse. Remember we talked about urge versus stress versus overflow incontinence, functional incontinence, or a mixture of those, and the kind of drugs that may make those worse. We also talked about the treatment strategies for each of those when it comes to drugs. And for urge incontinence, we often look at antimuscarinics or the beta-3 agonist maribegron, which is quite expensive, but avoid some of the antimuscarinic side effects. So that's important to consider as an alternative. For stress incontinence, usually in those circumstances, we look at pelvic floor exercises as the first line therapy, and all the rest of what's listed here in this slide are really second line therapy. And then for overflow incontinence, BPH being the classic scenario, our management, we talked about alpha antagonists or phosphodiesterase inhibitors, and one or the other because of hypotension, with the addition perhaps of a 5-alpha reductase inhibitor like finasteride. So all of those are sort of weighed against the symptom management. So important to sort of have a familiarity with those and where the drugs themselves bump into other concerns, orthostatic hypotension, if it's antimuscarinic, all the side effects you'll see. So here's a slide that sort of reiterates all of the antimuscarinic side effects of most of the areas that are used for urgent continence, all the antimuscarinics. They vary by product. And remember we said about mirabegron as well, it's a beta-3 agonist that doesn't have these antimuscarinic side effects, but look at the price tag of, if a patient doesn't have insurance coverage, about $450 a month for urge urinary incontinence management, which isn't perfect, but may offer some benefit. Big money if it's not covered by insurance. Our treatments for BPH we talked about, just keeping in mind orthostatic hypotension is the big concern with many of these, and the risks for managing those adverse effects, never using tadalafil, for example, with terazosin because of the additive orthostatic hypotension. Next were the drugs for rheumatoid arthritis, and most of these are going to be ordered by the rheumatologist team. But you should have familiarity with these, and you'll see these medicines for a lot of your patients on their med list ordered by the rheumatologist. First, the non-biologic disease-modifying agents, methotrexate being the standard, sometimes hydroxychloroquine or sulfasalazine might be on the list. The TNF inhibitors, for which either infliximab or Intercept or Humira are probably the three more common ones that we'll still use. The non-TNF biologics, Orencia, for example, is probably the big one here, maybe rituximab, also used as well. And finally, the kinase inhibitors, where Xeljanz or Rinvoq are sort of the two that are used more commonly here. So you kind of want to be familiar with each of these agents and what some of the concerns might be for comorbidities and how those patients get monitored or the degree to which those agents interfere with immune function in general. The next set of slides are in older patients who have gout risk. When they have a gout risk, you want to look at what are the non-pharmacologic lifestyle things, so weight loss and diet issues, avoiding things that are high in purine, as well as exercise and smoking cessation, and limiting alcohol intake. When someone does have gout, in staging what their severity of gout is by the degree of their symptoms, the duration of their symptoms, and how many joints are involved. And with the acute management, typically you're going to look at either colchicine or an NSAID, or perhaps maybe both if it's more severe or more joints are involved, or maybe celecoxib. And finally, in acute attacks, maybe considering corticosteroid like prednisone when you can't use an NSAID or colchicine. For urate lowering, it pretty much is going to be once the acute attack has abated, allopurinol is usually where we go, where we start therapy. Now that said, some of the newest guidelines are suggesting low-dose allopurinol during an acute attack, but most clinicians I work with still avoid allopurinol till the acute attack has abated. And so there is controversy about whether or not we will continue that or when we start allopurinol in light of the acute attack. The rest of the urate lowering agents are clearly, in my mind, a distant second line after allopurinol. They're expensive. They have sort of less safety data long term. They are often other side effects that we might be concerned about. And so they are really second line. And again, probenecid, an older therapy, or anything else that's listed on this slide for urate-lowering therapies, again, sort of second-line therapies. Okay, in a nutshell, that's a quick review of geriatrics. A lot of things you'll see in gerontology we did not cover here, but you will see all the time. So all the cardiovascular syndromes, including heart failure, you'll see all the time. More likelihood that you'll see pneumonia, more likelihood you'll see COPD and complications of COPD with exacerbations. More likely you're going to see thromboembolic events, AFib. All of the other things we talked about are more heavily weighted in gerontology that aren't listed here, but important for you to consider that. So in a nutshell, that's the summary of everything here. Look forward to bringing your discussion questions to class when you come to class with anything that you want to talk about one more time.